from what we've looked at that the oxygen can only be transported to the tissues in the blood. And this means there's got to be a good circulation of blood to transport that oxygen. And this gives rise to the next class of hypoxia we're going to look at, which is stagnant hypoxia. Now, stagnant means there's a relative stagnation or stasis of the blood. It's not circulating properly. And there's a variety of conditions where the blood does not circulate properly. And the first one I want to look at is shunting. Now, shunting is a congenital defect. Congenital means present at birth. It's a developmental abnormality. And it happens because the fetal circulation is very different from the adult circulation. So let's look at the fetal circulation now and use this to explain why we can get these congenital stagnant hypoxias. Now what we have here is a picture of the heart. So we've got the left atrium on that side and the right atrium on that side. You can see that the superior vena cava is coming down here, and as you would expect, the inferior vena cava is carrying blood into the right atrium. But in fetal life, the oxygenated blood, of course, is not coming from the lungs because the baby is not breathing. The oxygenated blood, which I'm drawing in bright red, remember we normally draw oxygenated blood in bright red and deoxygenated blood in blue. So oxygenated blood from the placenta, derived from the mother's circulation, the oxygen having transferred from the mother's blood into the baby's blood, into the fetal blood. This blood is draining back via this structure here, which is the umbilical vein, carrying oxygenated blood from the mother back to the baby. And that's going to go on, and it's going to go into the right atrium, as you would expect. Now, normally, of course, this will be deoxygenated blood, and that will go from the right atrium down to the right ventricle to be pumped out of the pulmonary artery to the lungs. But in the fetal lungs, we don't want a lot of blood going to the lungs because the lungs, there's no air going to the lungs. There's no point in that. So what happens is this oxygenated blood carries straight on through this communication in the septum between the left and the right atrium. It's called the Foramen Ovale. It is a communication between the atria. So this blood can go straight in to the left atrium. That means it can go straight on down to the left ventricle and be pumped out into the aorta, into the fetal systemic circulation. So that's good because most of the blood is going straight through and not going down to be pumped to the lungs. However, some blood does go down into the right ventricle. Some blood does. And of course, as you would expect, that is pumped out of the pulmonary artery. And that takes us on to the next fetal structure, the Ductus Arteriosus. Now here we have the main trunk of the pulmonary artery, which of course is leaving the right ventricle. And blood comes from the main trunk of the pulmonary artery, and of course normally it goes via the left pulmonary artery to the left lung and the right pulmonary artery to the right lung. But in the fetal circulation, most of it carries straight on through this structure here, which is the Ductus Arteriosus. And that communicates directly with this structure here, which is the arch of the aorta. So in the fetal circulation, the blood is going from the right ventricle into the main pulmonary trunk, straight through the Ductus Arteriosus into the aorta, where it can carry around the rest of the fetal circulation to oxygenate the fetal tissues, the whole body of the fetus. Now, normally, when the child takes their first breath, there's a flap that closes this off. So once a fetus once a baby's born, basically, that will be closed off and you'll get the adult pattern of circulation, meaning the blood is being pumped to the lungs. But if there's an atrial septal defect, this hole does not close off as normal, and that means there's communication between the blood in the right atrium and blood in the left atrium, and the oxygenated and deoxygenated blood is getting mixed up. That means that some oxygenated blood will be pumped to the lungs, which is inefficient, and it also means that deoxygenated blood will be pumped to the tissues of the body. So a lot of deoxygenated blood is pumped to the tissues of the body if this hole doesn't close up. This will be an ASD, an atrial septal defect. Likewise, shortly after birth, the ductus arteriosus is supposed to close off. It contracts and completely closes off, giving the adult pattern or the born pattern of circulation. But if for any reason the ductus arteriosus does not close off and remains patent, then again it means that blood carries on going from the pulmonary artery into the aorta. Again, meaning that deoxygenated blood is going from the pulmonary artery into the aorta, meaning that deoxygenated blood is being pumped to the child's body. Congenital cause of stagnant hypoxia. Other pathologies can develop during life that can also cause stagnant hypoxia. And these reduce the efficiency of the circulatory system. There is a sluggish circulation. And maybe the classic example is congestive cardiac failure. Now, in congestive heart failure, the heart is no longer generating an efficient cardiac output. And heart failure is when the cardiac output is insufficient to meet the metabolic demands of the body. Not enough blood is being pumped out to carry enough oxygen to satisfy the metabolic demands of the body. And what it actually means in practice is that the blood that's coming back to the heart is not efficiently pumped out. So what can actually happen is the amount of blood coming back to the heart exceeds the amount of blood being pumped out from the heart. That means there's a backlog in the venous circulation. You'll get an increased central venous pressure, because the blood in the veins is not able to get through the heart. The heart essentially becomes a bottleneck, and you get stagnation of the blood in the venous system. The blood's not going round, so the oxygen is not being transported, and numerous tissues will become hypoxic as a result of congestive cardiac failure. Now, the next one I want to talk about is shock. Shock means low blood pressure. We can define shock as a state of acute hypotension when the blood pressure is so low that it reduces the perfusion of the tissues. It will also reduce the oxygenation of the tissues. And it's for exactly the same reason. So shock is a state of acute hypotension resulting in reduced tissue perfusion and oxygenation. Because there is not the perfusion, the oxygen is not being carried to the tissues. So again, numerous tissues will become hypoxic in shock. Another cause of stagnant hypoxia is localized circulatory deficiencies and ischemia. A classic example of this is if the blood supply to the legs are inadequate, perhaps because there's atheroma in the large arteries going to the legs, the femoral arteries for example, then not enough blood is getting through to the leg muscles. And this means when the leg muscles exercise, they won't be getting enough oxygen. The metabolism in the leg muscles can change from aerobic to anaerobic. That will cause the buildup of lactic acid, and that causes pain. That particular pain is called claudication. The condition is called intermittent claudication because it happens after exercise. And when the patient has a rest, it will go off again. So localized circulatory deficiencies. Ischemia and infarct, fairly similar line of thinking. If there's not enough blood getting to a tissue, there's not enough oxygen getting to a tissue. And of course, an absolutely classic example of this is angina, myocardial ischemia. So in angina, the pain of angina is caused by myocardial ischemia. Not enough blood is getting through the coronary arteries because the coronary arteries are diseased. So the myocardium itself becomes hypoxic. And in stable angina, this is manifest when the metabolic demand of the myocardium exceeds the ability of the blood as it's delivered through the coronary arteries to meet the oxygen requirement of that metabolic demand. And that gives rise to angina. Transient ischemic attacks in the brain can be also caused by ischemia. And of course, infarcts is when there's a complete blockage of blood, and that's going to cause an absolute hypoxia. That's going to cause an anoxia. So if there's a coronary artery thrombosis, that will lead to a myocardial infarction and a complete absence of oxygen. And that area of tissue will die because of the absence of oxygen. You'll have an infarct. It's the same in the brain with a cerebrovascular accident. Most cerebrovascular accidents are thromboembolic. They're caused by thrombosis in the arterial system to the brain or emboli. But either way, the circulation to a part of the brain is blocked off. It will lose its blood supply, therefore it will lose its oxygen supply, therefore the tissues will die. Now in clinical care, pressure areas are a common problem. If a patient is immobile for any reason, it's absolutely essential that we turn them on a regular basis, because if not, the weight of the patient's body acting through the bones of the body will compress the tissues. And when the tissues are compressed to 25 millimetres of mercury or more, that's going to block off the capillary circulation. And again, if you block off the capillary circulation, you're going to block off the oxygen supply to the tissues. Those tissues will lose their oxygen supply, therefore those tissues will necrose, and that is what a pressure sore is. It is an area of tissue necrosis. And I think the last one I'll mention in this is edema. Now in edema, you're probably familiar with the idea that we have capillaries, and round about capillaries we have tissue cells. Now in edema, there's an increase in the amount of tissue fluid, the interstitial fluid between the blood going through the capillary here. Here's some red cells going through, look. Some red cells going through the capillary. The blood in the capillary and the tissue cells. Of course, there's supposed to be tissue fluid here, but in edema there's too much. There is an excess of tissue fluid. That's what edema is. And because there's too much fluid, that makes it much harder for the oxygen to get from the red cells. If you like, the oxygen has got further to travel from the red cells to get to the tissue cells that require that oxygen. And what we say is that edema increases the diffusional distance. Because there's more fluid here, there's more fluid for the oxygen to get through, so the diffusional distance is increased. And that will reduce the amount of oxygen and the speed of oxygen delivery to these cells. And that will cause a relative hypoxia of the cell and embarrassment of the cell. That is why edema is a risk factor for pressure sore development. Because if you've got pressure and increased diffusional distance, you have two factors, both causing hypoxic embarrassment of the tissue cells, both making death of these tissue cells more likely to occur.